Yeah, welcome everybody to this interesting panel discussion. So we're going to talk about changing concepts after the ischemia study. We are joined with a distinguished panel. We have a surgeon, Dr. Taggart. We have Antonio Colombo, who needs no introduction. We have Dr. Banning, and of course we have Dr. Park. So maybe let me just start with a quick summary. I mean, ischemia is the largest stable ischemic heart disease trial. It's still ongoing in the sense that we're following these patients longer term for up to 10 years of follow-up. The final follow-up is around 2026. So I'm curious to hear from people here as to what has changed in clinical practice. Maybe let's start with the left main disease. I mean, ischemia did not enroll patients with left main disease. What are the things that's kind of like, we have data from back in the day which showed that there is a survival benefit of revascularization. So what are the, current challenges and other unanswered questions in terms of left main disease? Maybe let me start with our surgeon in terms of your take on left main disease and, what do we do in terms of surgical treatment and where should the field move towards in terms of surgical management?
Thank you. I'm still convinced by the results of the EXCEL trial at 5 years. EXCEL was the largest, most definitive trial of left main. Now, albeit it was relatively select in that the patients had to have syntax scores below 32. So it was an intermediate group of left main, which would account for around 1/3 of patients in routine clinical practice, 2/3 of higher left main syntax scores. Now, I was very convinced by the mortality data in the EXCEL trial. There was a clear and accelerating divergence in favor of CABG at 5 years. Yet, as far as I can see, there has been a fairly determined effort to eliminate the results of EXCEL from the literature by combining it with smaller, weaker, underpowered studies until that mortality benefit of CABG in left main disappears. So I still think the best evidence we have today is the EXCEL trial, and I think it showed a convincing survival benefit of CABG, even in patients with intermediate left main disease.
So that's, thank you. And Dr. Colombo, so in your practice, so if you're choosing between PCI CABG for left main disease, what are your considerations?
I have a critique about the trials. The trials are important because they give general information, but nevertheless, we cannot use the trial to make decision for the patient in front of us, because each patient is a specific entity. We have a 48-year-old gentleman with left main disease who has a trifurcation, which may need 3 stents. That patient, even if he has a relatively low syntax score, is better maybe to consider CABG. On the other hand, if the patient is 79, has a total occlusion of the right corner, which can be reopened, a left main, which can be treated with 1 single stent, maybe that's reasonable to do PCI. So, you see, both may be appropriate for PCI, but in one we make a decision and the other we make a different decision. So that the heart team is very important because with the heart team we face the individual patient.
Yes.
All right. I want to ask, Taggart, if the lesion confined to the left main ostium and shaft, and no other epicardial artery disease, right? Do you believe still bypass surgery is better?
Interestingly, people say I often am critical of all PCI, and I'm not. I'm critical of inappropriately used PCI. And the one time I would opt for a stent, if I had true ostial or mid-shaft left main, not involving the bifurcation, and not with additional proximal coronary artery disease, I think the evidence of superb outcomes with stenting in that situation is very, very strong. And some of it came from Dr. Colombo's own group. So I think for true ostial mid-shaft isolated disease, I think stenting is an excellent option.
All right. So what I want to say is, even in the main bifurcation disease, I think it's a isolated main disease is totally different with it. All the randomized studies actually including the two vessel, multi vessels, consecutive disease, long diffuse. That's the main issue. If we focus on the main disease itself, just example, the osteal shaft lesion extreme cases. However, even in the bifurcation disease, all right, the epicardial bifurcation, LAD diagonal branches, obtuse marginal circumflex, even in the bifurcation, isolate main disease, technical concerns in the practitioner intervention side, I think it's good enough to manage it. So what I'm thinking is just however, main study, even in the randomized studies, registry studies, the main issue is combined three vessel disease. And so we're going to take separate with the isolate main disease and combine the two vessels, three vessels, totally different, outcomes. And so
Oxford was the second biggest recruiter to Excel. David and I did that together.
Yeah.
I've learned a lot since I did the Excel trial. And I do left main intervention better now than I did then. How do I do that? I do that with better imaging. I do it with better understanding of what I'm trying to achieve. And I do it with a better target of what I'm trying to achieve. And I think one of the limitations perhaps of the PCI versus CABBAGE trials is we've tried to compare ourselves with surgery too soon. In syntax, we were trying to do multivessel disease with 12 stents. We were learning while we were doing a comparative trial. Well, that was clearly wrong. So I think we have learned better with the left main. We need to understand where the plaque is. We need to make sure that we do a really good job. We need to take our time. And I think there's a strong argument that you shouldn't be doing left main unless you're an expert. And I think one of the problems we have potentially is people don't understand that. If you can't image, if you can't use the rotablator, if you can't make sure you get a fabulous result, then you shouldn't be doing this case.
But, very frequently in left main disease, the big problem is not the left main, it's the associated disease in the other vessel. Because, the left main is such a big vessel per se. You place a stent from left main to the LAD, most of the time you just keep the circumflex open, that's it. But sometimes you have a long disease of the LAD, downstream you have a LAD bifurcation disease with a diagonal branch, big obtuse margin, another bifurcation, and you end up having a patient that has two stents on the left main, two stents on the LAD diagonal, another two stents on the obtuse margin, one long stent 38. He ends up...
And I think the risk with that sometimes is because there are so many stents going in,
the
stents are not put in well.
But even if they're put well, I think the idea that the stent put well is something that's durable for eternity is wrong. Even if it's put well after 5-6 years, it's still unphysiologic.
Interventionist point of view, main vessel is big one, very proximal part from the guiding, very honestly very good target for stent procedure. Simply crossover to center. So what I want to talk is main itself is not a big deal in combined epicardial artery disease more. So Bangalore, you want to move to guideline concern about the main, how much change, and then move to the
I think this was fascinating discussion. Kind of completely agree that in clinical trials you have average treatment effect, and the question is how do we apply that average treatment effect to individual patients? And that's why I think I must say across both ESC and ACCHA guidelines, emphasis on heart team approach, individualize your treatment options, and I completely agree with Dr. Banning. I mean, you're absolutely right. If you look at imaging guidance in all of these trials, I mean, you would be surprised how we can do a clinical trial of left main disease with not much imaging, right? I mean, in clinical practice, we would never do any stenting of the left main with no imaging. So I think those are all some of the things that needs to be considered. But I think individualizing patient decision, based on what we see and the anatomic complexity. I've had patients, we have to also take into consideration what the patient wants. So I think it's and that decision, David, I'm curious to hear from you. And that decision can only be done if both the surgeon and the cardiologist and interventionalist speak to the patient and give their own perspective of their own. Interventionalists talk about intervention, surgeons talk about surgeon. So what do you think how best to approach a heart team discussion?
I don't think it's a good idea, the physician speaking to the patient and then the surgeon speaking to the patient, because that will, even if done as best as possible, is going to create confusion. I'm a strong believer that patients who may need revascularization, it should be presented to the heart team. The heart team should come to a recommendation, and that should be documented in the case notes. And then the patient should be told, your case has been discussed by a team of experts, and we believe that for the following reasons, this is the best treatment for you. Now, in the UK, if you say that to patient, in my experience, about 98% of patients will take that recommendation on board. But I think it's better being presented to the patient from the outset that the decision has been achieved by a team of experts, because that gives the patient confidence. And I don't like the concept of individual doctors going to speak to the patient, because we all know how easy it is, even just by the way you look at a patient or say something, you can convince the patient of anything. So if the patient's confident the decision's been made by a team of doctors, it gives that patient confidence.
Yeah, and moving onwards, Dr. Colombo, I was interested in your take, having too many stents. I mean, for left main, what do you think would be the role for drug-coated balloons for that matter?
But we need to do studies.
Yeah.
I think I'm not promoting drug-coated balloons. I'm promoting studies utilizing drug-coated balloons. We need data, but if we need to improve PCI, stents is a good idea, optimizing stents is a good idea, but may not be sufficient. My goal is to eliminate surgery. But if I want to eliminate surgery, I need to do something more than just placing stents well. I don't know, maybe I will never be able to do that, but with the tools that I have now, is not sufficient. So,
but this is it's not a new tool, it's an old tool used again. I agree with you. I think we need to sort of look at how we treat, particularly the vessels downstream. I'm not sure the ostium of the circumflex is going to be the drug-eluting balloon target of choice. The ostium of circumflex, in some respects, is the exact opposite of where we want to be. Difficult to dilate, a high restenosis rate, difficult to get a mechanical dilatation at that point. But I think drug-eluting balloon elsewhere is a huge option and quite exciting.
I think the idea to stent from healthy to healthy is debatable. I put this idea into the field, but at that time we had 15 millimeter palmar shunt stents, so we were treating focal lesions. But when I see on the shelf 225, 48 millimeter stents, I don't understand why they even sell 225, 48 millimeter stent. Well, they want to do it.
Yeah.
But people place these stents.
Absolutely. I think, I think that also goes to the concept of like, if you have too much diffuse disease, I mean, we have to really make sure medical therapy is very optimized. I mean, we have a number of options. And one of the things that I want to also pitch for is what is in the pipeline. If you look at all of these trials, none of them use PCSK9 and all of the medication.
For example, if you have, especially for the LAD, if you have a lung disease in the proximal LAD, a lung disease, I don't necessarily mean diffuse disease, a disease that you place 230 millimeter stent, 60 millimeter stent on the proximal LAD. Even if it's well placed, I don't know after 6-7 years what's going to happen.
Right.
I think the other danger inherent in this philosophy let's keep changing the stent from balloon angioplasty to bare metal stent to drug-eluting stent to new generation of drug-eluting stent. This fails to understand the benefit of bypass grafts. And by placing the bypass graft to the mid-coronary vessel, you're adding protection against future proximal lesions. Plus, if you use the internal mammary artery, you get the benefit of nitric oxide eluted by the mammary artery into the native coronary circulation. So I don't believe in this philosophy of the cardiologist when they keep saying, right, we've now got a new stent.
That's right, David, but it's not right, because the new stents are safer.
Yes.
You know, and that is a really important point. And what we showed in Syntax 2 was that with newer stents, we've reduced the stent thrombosis rate. Stent thrombosis is disaster. You know, we reduced the MI rate. We reduced the need for dual antiplatelet therapy. And you know, in a comparative fashion, our results appeared to be similar to bypass surgery that was done in the Syntax trial. So I do think intervention is evolving. We've talked about the use of physiology. We haven't talked of imaging. We haven't talked about the use of physiology to select when we should be treating, and that interfaces with ischemia well. So I think we understand better as interventionists where we should be treating it, but we are able to get a safer result. And ultimately, that's hugely important for our patients.
Yeah, and I think that's one of the biggest things we have done. I mean, if you look at stent technology and the outcomes with it, I mean, we have published a number of meta-analyses clearly showing we have made significant strides in even reducing death.
Yeah.
I mean, not just MI, stent thrombosis, death. And if you see what we were talking in the TCTAP, we are talking about shortening the DAP duration. I mean, a decade and a half ago, we were saying just continue forever, because we didn't know that when these stents are going to thrombose. And now we have come all the way around, and now we're just trying to see which shorter the DAP duration potentially is better. Let's not expose them to bleeding risk. David, just a quick question on just keeping with the surgical one. So what's your thought on multi-arterial grafts? And, I must say in clinical practice, I mean, everybody talks the talk, but nobody does it. I mean, you know, we
I mean, it's a very good question. And we know angiographically, if you take the two mammary arteries, we know from the 10-year data that they would expect to have patencies about 90%. It barely changes out to 15 years. So that's the evidence that we have. And if we believe that complete revascularization is important, then having two patent mammary arteries in your heart intuitively and biologically must be good for you. But I do accept there has been a general reluctance in the surgical community to use these grafts as widely as they should. And I think the part of the reason is that all surgeons are judged on short-term outcomes. And doing two arterial grafts is a little bit more difficult than doing a single arterial graft. And nobody's interested in long-term outcomes. You don't get rewarded for it. But interestingly, in Canada, you do get paid more if you use a second arterial graft. So we need incentives. But I think the mindset of the surgeon is just to keep things as simple as they can, because that's all they're judged on in the short term.
I mean, I have a question for David and also for the... knowing the benefit of the mammary, I think the benefit of the mammary are clear. Why hybrid procedures never took off? Combining PCI on the right, on the circumflex, and in a separate session, do mammary to the LED. Makes a lot of sense, but there was a randomized trial with the NHA LBI supported
which was abandoned.
That was abandoned.
I think that's a great point. I mean, the trial was abandoned because of poor enrollment.
Yes.
And it again points to the fact that, we talk about all the heart team discussion, but we still are practicing in silos, right? I mean, I think we really need the best of both worlds. And I think everybody will agree you cannot beat a Lima, right? For everything else, I mean, that drug-eluting stent should suffice.
But perhaps an intermediate compromise is, and this can create a bit of tension, but there's increasingly strong evidence that the radial artery, it may not be as good as a mammary artery, but it's certainly better than a vein graft. But of course, it's also the route of preferred access for the cardiologist. But that's something we need to kind of think about in patients who are potential candidates for bypass grafting, is to try and ask the cardiologist to make sure not both radial arteries are used.
Yeah,
And that's, sorry, the point I was going to make, that's technically more easy than using a second mammary artery, and especially in an obese diabetic patient, it's much safer.
yeah, I mean, typically, I mean, we use the right radial artery,
Yeah.
and the non-dominant one is used for grafting. And at least now, again, to going back to Dr. Banning's point, I mean, technology has evolved, and the way we do radial PCI has also evolved. Patent hemostasis, the damage done to those radial arteries are also minimized. And we know from a number of randomized trials that radial access has benefits, including a mortality
Yes.
reduction. Okay, so any final thoughts on?
Right.
I might just say that, I pick up David's point, I don't see many patients where there's great debate about which revascularization strategy we should use. I think if you sit down with the angiogram and the surgeon and the patient, or who knows the patient's data, the decision comes through
Yes.
as to which is the right therapy. And it really is, that's where we are now. We just need careful analysis of the data, thoughtful consideration, and as David said, make a decision together and get on and get it done well.
Dr. Park, any final thoughts?
It's okay.
No, I think this was fantastic. Thank you, everybody. And I think the key take-home is individualized patient decisions
Yes.
and optimize your revascularization strategy.
Yeah.
I'll thank all the panelists on this.
Thank you.
Thank you.
Thank you.